You're listening to the Fertility Docs Uncensored podcast, featuring insight on all things fertility from some of the top-rated doctors around America. Whether you're struggling to conceive or just planning for your future family, we're here to guide you every step of the way.
Hi, everyone. We're back with another episode of Fertility Docs Uncensored. I'm one of your hosts, Dr. Abby Eblen from Nashville Fertility Center. And today I'm joined by my fascinating and funny co-host and friends, Dr. Susan Hudson from Texas Fertility Center.
Hello.
And Dr. Carrie Bedient from the Fertility Center of Las Vegas.
Hey.
Hey. So what have you guys been up to lately? It's been a little while since we've recorded, so we've not gotten to catch up with each other.
It has. We just watched the third Harry Potter movie the other night, and I spent a large chunk of the time covering small eyes with my hands for the scary parts.
I remember watching those as an adult, covering my eyes on the scary parts. Not my favorite kind of movie. Well, actually, it was good, but I didn't like the scary parts.
Turns out the Dementors are really frightening.
They're pretty creepy.
Yeah.
I'm hoping that this summer we're flying through London, and so I'm hoping we can go do like the little Harry Potter tour thing.
Oh, that'd be cool.
That sounds very fun. So I was just telling Carrie, I watched an old movie the other night, Bridget Jones' Diary, and it was so cool. I just remembered that I left the movie with that happy feeling, but I didn't really remember a lot of the details because it's been so long ago since I watched it. But it is hilarious. I laughed. Bridget is very funny.
That was one of our college go-to movies. Like there were four of us in our apartment all during college, and we would frequently turn on Bridget to get through, Friday nights, Saturday nights, whenever we didn't really have anything else to do. And we were just like sitting down with a bunch of popcorn, some candy, and watching Bridget and her exploits.
I love it. And it's such a great soundtrack.
Yeah, it is. It is. I think one of the funnier parts is when she went running out after him. If you guys remember, there was a scene where it was snowing and he'd seen something written down in her diary that was really mean things about him, that Colin Firth, the main guy that she liked. And so she saw him leaving and she just grabbed a sweater and she had like her underwear on. It was leopard print underwear. And she went running down the street. Yeah. And that was, then they like embraced. It was like such a, happy moment at the end. And
we should have the official underwear of Fertility Docs Uncensored be leopard print.
Oh, I like that. Although I will say, I didn't know we had official underwear, Carrie. Is that a new thing that I don't know about?
Well, we do now. You can choose the style, boy shorts, thong, granny panties, whatever. But I feel like the official underwear of FDU is going to be leopard print in honor of Bridget Jones.
It's going to be our first, not bling, but swag.
Yeah.
FDU leopard print undies with our little symbol on the butt cheek.
Yeah.
I think it should have like a lucky charm on it somewhere, like you take this underwear off and you get lucky. Let's be real. Nobody wants swag with a mug that says Fertility Docs Uncensored on it. But hey, underwear might be kind of like, good karma or something, for fertility.
It's like your pineapple socks.
Yeah, there you go.
Yeah. Or the pineapple earrings. I saw one of my surrogates came through with pineapple earrings, shirt, and socks. And of course, she wasn't wearing pants or underwear because we were doing a transfer. So maybe underwear is not a good idea. I don't know.
Maybe you guys can let us know on Instagram or Facebook or something if you have a preference for socks or underwear with our swag on it. Maybe you don't care for either, but let us know one way or another.
That would be good. All right.
We've got some questions today. Susan said we have about 40 questions. I don't think we'll get to all of them, but we're going to...
As many as we can.
All right. So our first one is, hello, I am 41 years old and have gone through 3 IVF cycles due to ectopic pregnancy and have 1 tube that has scar tissue. First 2 IVF cycles resulted in 5 eggs, but never made it to blast at the age of 35 and 36. Last retrieval had 3 eggs and doctors suggested they do implantation on day 3, which obviously didn't work. And she was 40 at the time. Next step recommended is egg donor. My question is, should I go with an egg donor and do another IVF cycle just to make sure that it is egg quality? My husband wants to just do egg donor, but we have questions as to why the embryo did not implant. Genetic testing was normal for both of us. Sperm analysis was normal.
So she had 3 cycles and one of them, she did have a transfer. Was that the fresh day 3 transfer on the last one?
Yeah.
And it didn't implant. Yeah.
Correct. At 40. And now she's 41.
So the thing that bothers me is that her first 2 retrievals were at 35, 36, and she only got 5 eggs in each of those retrievals. And that's
not pure tubal factor at 35, 36. There was an egg thing going on 6 years ago.
I would agree.
I think when you're proceeding, like some of it is going to be your comfort level. I think you're more likely to hit success with an egg donor. But if you're not going to be comfortable doing an egg donor until you do one more cycle on your own, then you got your answer there, because
this is a hard decision.
Yeah. Like you'll spend the time and the money doing one more cycle. The egg donation, I don't care about that because that's independent of your age. And so I think you do what makes most sense to you guys as a couple and what will make you comfortable moving forward with egg donation. I think there are a lot of people who would say, screw it, I just want a baby, let's move forward. And there are going to be other people who say, I just need to try one more time. And mentally, I am prepared to move forward with egg donation if this doesn't work.
But if what you're wanting to hear from us is, do we think that this is an egg issue and not just a tube issue? I think I can say, yes, we think that this is an egg issue. You have eggs and tubes as an issue. So if from us, that's what you needed to hear, I think we all feel that way too.
Well, and the answer to why did the day 3 embryo not implant? Again, it probably was just not a very good quality embryo. And there's millions of things that have to happen for an egg and a sperm to go together and to fertilize and to implant. And I get that question a lot, like, well, why didn't it implant? Why didn't it grow? And the answer is, I don't know. I mean, there's millions of things that could have happened to make it, not go successfully. So it's disappointing, but unfortunately, that's the question that everybody has that no one has an answer to.
Yeah. All right. Our next one is, hi, Fertility Docs. I'm wondering about the impact of stress on infertility. My husband and I conceived our son, now 2.5 years old, in the first month of trying. And now we're almost a year and a half into trying for our second child. I'm 31, he's 33, and all our tests are normal. So technically unexplained infertility, which is a frustrating diagnosis. We just had our first failed IUI and we're reflecting on the past month, 2 weeks of daycare closures for our son, and a week of my husband in bed battling a bad cold and me resenting him for that. Plus, we recently moved cross country and there's still a pandemic going on. Could the stress be impacting our fertility? What about colds and minor illnesses? Thanks.
What I always tell patients when I get that question is, it's really tough to design a study to look at those kinds of things. I mean, I think stress impacts us in many ways that we don't understand, not just our reproductive system, but every other system in our body. We know that cortisol goes up. We know that that's a bad thing. We know if people are under really severe stress, they even stop making eggs. So we know that stress impacts our reproductive system, but it's really hard to know in this particular situation, how it really impacts the egg and the sperm getting together. And it's hard to design a study like that because what impacts you and is stressful for you may not impact somebody else in the same way. So it's just hard to kind of figure that out. So I don't think anybody really knows the true answer to that.
And also realize when you're doing IUIs, you're probably doing something that has about a 15 to 20% chance of pregnancy per cycle. So there's so many things in that equation. Was the illness, was the stress, were those things contributing? It's possible, but I think there's reasonable data to say that severe acute stress probably has an impact. But what I call good old American stress, unfortunately, the studies really don't show that it has that much of an impact. Even it seems kind of counterintuitive. And as corny as this sounds, I try to encourage my patients not to stress about stress because there's enough for you to stress over. All of us, we sit there and stress about our patients. And, it's like you actually have people who are worrying about you all the time, and take comfort in that and shift a little bit of that onto us so that you can be getting yourself in the best place possible.
Agree with all of that.
All right. So our next one. Hi. So thankful for your podcast. I'm going to be starting my IUI journey in March. I am going to be entering in a FAMEA. It might be FAMARA. IUI trial where they use a different catheter. The catheter goes right into the fallopian tubes.
Oh, yeah. Sorry.
So it is FAMEA.
Wow. Carrie seems excited about this question.
I was wondering if you guys have seen or heard anything about this. We are a combo of female and male factors, so I'm leaning towards it's a great idea since it would be a shorter swim. What are your thoughts? As I'm not familiar with the name, I'm going to let Carrie take this one.
Carrie seems to know about this.
So this is a new catheter, and our center was approached to do a study with it. And so the difference between this catheter and a standard IUI catheter is that a normal IUI catheter just goes in with the intent to put the sperm kind of at the top of the uterus, and then it swims in whatever direction it goes in to find the egg. And typically the hormonal influences of the side that releases the egg help the sperm to favor that side because the fallopian tubes are helping to beat those cilia, those tiny little hairs, to help the sperm go in the appropriate direction for whatever side is releasing an egg. So the difference with this catheter is that it has a direction to it. And so when you put the catheter in, it goes into one tube and then it blocks that tube so that you put the catheter into it, you block it behind it. So any sperm that you're putting in there is going to go into that side and it's not going to come back out into the uterus. And so it gears it towards that side. And you do it under ultrasound guidance.
Is it like the catheter when we're trying to do cannulation of the tubes, that kind of catheter, or it just sort of gets it over to that side and blocks it off from going to the other side? Like, do you have to get it actually in the tube physically when you're doing
You have to get it at least in that cornua. And there's a tiny little balloon that blocks it, which is different than the cannulation catheters we use.
Gotcha.
So that's the thought behind it. Like, I don't know that there's any damage to doing it. I don't know what the data is going to show that it's more or less effective. I mean,
it's really a trial.
Yeah.
It's a trial. I mean, the trial seems well designed. Our center was willing to do it because we think it's a good design, but it's a trial. So we don't know. I don't think it's going to do any harm. I don't know if it's going to help, but I don't think it's going to do any harm.
The only concern I would have, and I mean, I guess I've looked at this is, and maybe you don't generate enough pressure to do this, but if the little egg is floating halfway through the tube and then you flush fluid that flushes it backwards, what's the likelihood that it'll flush and you have a tubal pregnancy or something?
You get an ectopic because it goes too far in the direction.
Maybe the pressure's not high enough that you can generate enough pressure to push the egg that far back up.
Yeah. I mean, I think the pressure is just the normal pressure that you put in for inserting sperm. So it's not going to be huge, but if it is going directly into the tube, I guess that could be a possibility.
Hopefully that won't be the case.
Yeah. So, worth a try. I don't think there's any harm in doing the trial.
Yeah.
All right. Our next one. I just went through my first failed cycle of IVF. Just for a bit of background, I'm 36, husband's 38, AMH 3.4, which gave her hope. I had laparoscopic surgery for stage 1 endo 2 years ago and a hysteroscopy to remove a few little polyps in my uterus just before I started the IVF cycle. My first stem resulted in 8 eggs, 7 mature, 6 fertilized with ICSI, and 6 began dividing. However, my doctor did say that they were not great quality. We did a day 6 transfer, and by that time, 4 eggs had degenerated. 1 had only made it to the morula stage, and I had 1 blastocyst that the doc didn't seem too thrilled with. He went ahead and injected them both as I had imagined. Neither one stuck. My question is this: should I expect low egg quality in the future cycles as well, or can quality vary from cycle to cycle? I am also just curious how hopeful y'all are that this process of IVF will eventually work for me if I stick with it, with all things above considered. I feel pretty discouraged right now. Thank you so much for this podcast. I learned so much from it, and it gives me a lot of hope in the process.
My gut feeling, if I had a patient like this that I was talking to, I would look at her age, which is 36, and her AMH that's 3.4. 3.4 kind of means that she should have a pretty good number of eggs. In our practice, that would be like 15, maybe 15 to 20 eggs. And she only got like 8 eggs. And so
but she's got endo. So like you usually see kind of a decreased yield with endo.
Yeah. So maybe a little bit of a decreased yield, and that could affect sometimes the quality too. But if it were me personally, I would ask her or kind of talk her into trying to do another cycle. Cause I just feel like, we learn something from every cycle. And I think no matter what your cycle was, no matter what your stem was, your doctor can probably look back at it and go, gosh, maybe we could do this to maybe see if we could get a few more eggs. And if we get a few more eggs, maybe we'll have better quality. Maybe they look back and say, in reality, maybe we should have pushed her another day, had her get another day of medicines. Sometimes if the eggs are a little bit on the immature side, they don't fertilize as well, they don't develop as well. If it were me personally, I would feel like that you could probably do better. And so I would really try and talk you into kind of maybe do another stem cycle. If the next stem cycle is very similar, then I would be less optimistic. But I think it'd be worth trying again, just because I think there's some things that probably can be manipulated a little bit to, make you do better.
I would agree with that. I think that oftentimes doing a second cycle, in addition to learning more, I think there's a priming effect of the medications. And so you would never do just go through all the IVF meds just for the hell of it to prime. You would want to go through and try and get those eggs, because a lot of time we do hit it on the first time. But I think many times we do a second cycle and get better results from it. Not all the time. Cycles are different from month to month, and those eggs can be affected by whatever's happened in the prior 3 months. So if you got really sick in the past couple of months, then I would say maybe give it a little bit more recovery time. But I think you can potentially benefit by doing another cycle. You don't know unless you try. And I wouldn't give up, and I wouldn't give in to the despair and the disappointment that comes in. I just say like, all right, we're going to do it again.
All right, let's do another one. I wanted to say how much I appreciate your podcast. I learned so much about infertility in a short period of time and couldn't be more grateful to you ladies. I was very prepared and ready when I started my treatment, thanks to you. Thank you. That's so sweet. Thank you for letting us know that.
Oh, yeah, that was very kind. Thank you. Thank you.
I also appreciate that you talk about a range of subjects that impact patients, which is why I want to ask you this question. Up till now, I was very happy with the REI practice I decided to go to. My REI doctor and the entire office has been great. I went through 3 egg retrievals successfully, but now there's been changes happening to this office, and I am suddenly having a lot of difficulty scheduling my appointment with my REI doctor. They are now pretty aggressively trying to schedule me with a nurse practitioner for my follow-up office visits, which I am furious about. No disrespect to NPs, but I came to this practice for treatment because of the reputable and experienced REI specialist, not to be treated by an NP with very limited training and experience. I'm not sure what NP should and should not be doing in this specialty, but please tell me what rights I have as a patient to see my doctor and refuse care from a nurse practitioner. I would appreciate your perspective, as I'm very upset and don't know what to do. I feel like I'm being cut off from my doctor, booted off to an NP. Does this seriously happen in the REI world? Thank you. That's a great question.
That is a great question. So a lot of practices need to use NPs or PAs because there are just not that many REIs in the world. There's only about somewhere between 30 and 40 REIs who graduate every year. And right now, if you look at the number of practices hiring, it is easily 3 times that. And so like much of the rest of the world right now, everyone is trying to hire, and there are just not enough bodies to go around. And especially when you consider, the 15 years of training we go to get to this spot, it's hard to get those bodies in. So a lot of people use adjunct medical providers in order to help with that. Now, what your rights are and how that impacts your care is going to be different from practice to practice. So as a patient, you always have the right to say, I only want to schedule with the physician. That is totally fine. But there's going to be a trade-off because the physician only has so many hours in a day, and most of us work pretty long days as it is. And so in order to give the care that we want to give, you can only schedule so many people. And so you're probably going to end up waiting longer because of that. And the demand for fertility services has not gone down, but the supply of people who have the extensive training to do that also has not appreciably increased. And so there are a lot more places that need to use adjunct folks in order to do that. Now, it depends on the oversight of that. And so there are a lot of nurse practitioners who've been working in the fertility world for a long time, and they're really used to it. There is a lot of pattern recognition there. And once you hit those patterns, you can kind of tell normal, not normal. And pretty much all of us are OCD about our patients. And so it's helpful if a nurse practitioner can talk to them and allay some of the fears and go through the process, because that doesn't have to be an REI. Where you want the REI is you want them supervising in the medication protocols, in doing the procedures, and the input with the lab. So they're not going to necessarily be running the lab, but they're going to know what's going on in the lab. And so I think it just kind of depends on how your practice runs. Like they're just like all physicians are not created equal. All nurse practitioners are not created equal either. Some are really amazing and some just don't have the experience. And so I think it just depends on what you're doing. Like a lot of what we do is very repetitive. And so it makes it such that our staff can learn what we do. They don't necessarily know the physiology behind why we're ordering whatever we're ordering, but some of the people who've been doing it a long time are good at the pattern recognition, and they can say, hey, that doesn't look normal. And in a good practice, there's a lot of communication going back and forth, and the docs are looking over every single lab, every single ultrasound that goes through. So they can say, yeah, that doesn't look good. Let's change plans. So it really depends.
I think everybody has the right to choose who they want to see. And if they don't feel comfortable seeing a person, no matter who they are and what practice, then they need to, see who they want to see. But I would agree with Carrie. It's just the supply right now of people that can see patients is just dwindling. And just like she said, we have supply chain issues and nursing shortages. And so it's just really difficult to get people in the speed that they want to get in. A lot of times in our field, if you have to wait, a few weeks for your primary care doctor, for that, sometimes it's not as big of a deal. In our field, we see a lot of people that will do IVF and then immediately want to do another cycle. And, that just takes manpower. And so we try and get patients in really quickly. We try and do our best to, give them very good care. But a lot of times just the speed at which patients want to be seen in our field, because if you have a failed cycle, a lot of times you want to go right back into cycle. It just sometimes calls for using, nurse practitioners who are experienced in the field.
Both of you have nurse practitioners. Nope. Carrie, you don't?
No.
Abby, you do?
Yes.
Okay. We don't have nurse practitioners either. I want to reiterate what Carrie and Abby have said in that one of the beauties of the fact that we have been able to make infertility something that people talk about and they seek out care for and are proactive in getting that is that we are having more and more patients. We are in certain parts of the country having more access in the meaning that people are getting more coverage for fertility care. So people who previously chose not to seek out care now have coverage and they're like, hey, maybe we can't go and work on having a baby now that we have coverage. But like they said, we have historically, for decades, only had about 35 to 45 new REIs for the entire nation each year. And that's a teeny tiny number. We got 50 states, okay? And granted, populations in those states are not obviously equal, but there aren't enough of us. And so if you want to see your doctor, I am sure your doctor is very happy to see you, but you might have to wait because there's only so many hours that we can see patients. And believe me, we do all kinds of crazy things to try to get our patients in as quickly as we can. It's hard. I know in the situation where when my kids are having to go to the doctor, half the time they're wanting to schedule them with a nurse practitioner. And as a physician, I'm like, I'm pretty sure, yes, I do not practice pediatrics, but I'm like, I did go to medical school. I did go through pediatrics, all those types of things. And so I'm not always excited when that happens, but when I know it's like, okay, this is something that should be within that scope of practice. But there are times when things are more serious and I kind of make a judgment call of when do I bend and see the nurse practitioner and when do I not bend? And I'm like, I have to see a physician for this visit because there are times. And so we don't want you to do something that's uncomfortable for you, but it is a trade-off, unfortunately. All right. Our next one. Is ICSI really required for PGTA testing? I am experiencing secondary infertility and recurrent pregnancy loss after having a quick, healthy, and easy pregnancy with my 2-year-old. So we are moving on to IVF after one natural pregnancy that resulted in a DNC at 9 weeks, a chemical pregnancy from a medicated IUI cycle, and another DNC at 9 weeks following another medicated IUI cycle. I have severe DOR at the age of 30. I have an AMH of 0.4, antral follicle count of 6 to 7. I knew of my DOR diagnosis before my first pregnancy at 27, but got pregnant a week before starting stems to freeze embryos. My husband is 11 years older, but had a good semen analysis back in 2019. However, now his parameters have decreased. His count is high, over 100 million, motility normal, forward progression 2%, morphology 2%. So this has been determined to be a factor contributing to subfertility. I am pretty certain we could get pregnant again from medicated IUI, but I really don't want to waste more time and risk another miscarriage. So we're heading to IVF. Although I know PGTA testing for under 35 cohort generally doesn't result in higher live birth rates, given my previous losses, we, doctor plus us, are all in agreement that PGTA testing would be a good idea. I am nervous, however, about ICSI, as I have heard it can actually hurt success rates for women with low egg count, and the long-term effects of ICSI on offspring are still unclear, unknown. My doctor is telling me we have to do ICSI to do PGTA, but I have heard that it's not actually necessary to do ICSI for the newer tests they have, and I'm at one of the top fertility clinics nationwide, so I'm sure their tech is cutting edge. Thoughts?
I mean, you don't have to do that if you don't want to. I think in our center, Amy Jones, who does all the PGT testing or is involved with that for Ovation for the company that we work with, really feels like that we get better fertilization, or she feels like that our center gets better fertilization by doing ICSI. And when you only have a limited number of eggs, you want to get the best fertilization you can. There's no absolutes in our field. If you feel really uncomfortable about it, you don't have to do that. The biggest issue is if you only get 2 or 3 eggs and say we put it with the sperm in the Petri dish, not do ICSI, if we don't get great fertilization, or if we don't get any fertilization at all, then the ball game's over before it's even started. And so I think it really depends on your concerns. And I would certainly talk to your doctor about it and just say, I'm not real comfortable with this. Could I do something else? Could I do just insemination in the Petri dish? And I'm sure they would say yes, but I think they feel like that they're doing the thing that would be the most helpful for you. And, in our center, I would say the great majority, and I probably with you, with Susan and Carrie also, the great majority of cycles that we do ICSI. So I feel like ICSI is a good procedure and it works really well. And I would have no qualms about doing the ICSI.
I mean, we do ICSI on pretty much everybody. And technically, you probably can avoid it in doing PGTA. The reason we like doing it is because it nails down the timing. And it also makes sure that every egg has the opportunity to be fertilized. And in DOR, that does help allay some of those concerns of, if you only have 3 eggs, you want to make sure that they've all had a crack at being fertilized. And there's always going to be a 3 to 4% background risk of birth defects, no matter how you get pregnant, IVF naturally or whatever. However, when you have a known male factor, that adds another 1 to 2%, particularly of genitourinary abnormalities. And that's related to the underlying sperm. That holds true whether or not you get pregnant through IVF with ICSI or naturally. That's an issue inherent to the sperm, not necessarily inherent to the process of how you get pregnant. So that's going to be there anyway. And yes, everybody's watching to see if you do XYZ treatment, what happens to the children. And that takes a long time to figure out. ICSI has been standard for quite some time and very commonly used. So I probably wouldn't think a whole lot of it using it because they're going to choose the best sperm they can, the best swimmers, the most normal appearance. And that's going to help the hopefully right one get to where it needs to be.
Though, if you are doing PGTM, so looking for specific genes, ICSI is absolutely necessary in that point. So just in case somebody's having to go down that route because they're a carrier for some sort of genetic disease, in that situation, it's not a discussion point. It's a have to.
And I'd like to echo what Carrie said. I was trying to think back how long, for my entire career, I started in 1998 and we've been doing ICSI, and it wasn't quite as routine for the first couple of years, but I would say for more than 20 years, it's been pretty routine treatment. It's not experimental by any stretch of the imagination. And I would really think by now, if it was really going to have a significant negative impact on any aspect of what we do, we'd know it by now after 20 years.
All right, let's do 1 or 2 more. Okay, I am 34 and my husband's 36. We have been trying to conceive for 18 months. I was diagnosed with mild hypothyroidism in 2020 and take medication. But other than that, we have no known health issues. We did our first round of IVF in late 2021 that resulted in 6 fragile eggs. 4 did not survive the stripping prep for ICSI. 1 fertilized, 0 embryos. We just did a second round of IVF in early 2022, took DHEA, did a priming month with testosterone, and also added Omnitrope along with adjusting with other medication dosages. My AFC is 11 for both cycles, but this round produced 14 eggs, all mature, 13 survived ICSI. And on day 1, we had 8 with pronuclei. We ended up with just 2 day 6 embryos, a 6BB and 6BC. They are now frozen and we are waiting for chromosome testing results. My question is, since our goal is to ideally have 2 more children, should I do another IVF round now rather than immediately moving forward with FET if one of our embryos is chromosomally normal? Since it seems I have an egg quality issue, I am concerned that the odds of successful rounds will only be worse if I am trying again at the age of 36 plus. I love listening to your podcast and would love to hear your thoughts and advice. Do it now. Create embryos now. Don't wait.
Do it. That's a great question and an easy answer. Go for it now. Don't wait till after you have a baby, for sure.
Your thinking is exactly correct. Time is not going to do you any favors. You already know that there's an egg issue. Run with what you got and do it now. If you know you want 2 babies, give yourself the best chance possible.
All right. Good stuff. And Our last one for today. Hi, first off, love your show. It has taught me so much. I'm 30 years old, diagnosed with skinny PCOS. I've been seeing RE since August 21 and have tried 3 rounds of letrozole, 2.5 milligrams with just timed intercourse for 2 months, and then 7.5 milligrams last month with IUI. They gave me a choice of 1 or 2 IUIs last month, in which we chose one to start. It was not successful, had 1 follicle 22 and a half and the other 18. We are trying again with 7.5 of letrozole and another IUI cycle. My egg count is good, usually 10 to 11 follicles on each side before starting letrozole. Saline, HSG, endometrial biopsy all looked perfect. Sperm at last IUI was at least 86% motility. Woo! And no other issues with my husband. Question, doc is giving a choice, 1 or 2 IUIs this month. How would I decide?
We typically just do 1 IUI because there's not really a whole lot of data that shows 2 makes any difference, and it increases your expense. And so we typically run with 1. What do you guys do?
We do only 1 too, for the same reasons. We don't think it will help if you do 2 and just increase your expenses and visits to the office.
We only do 1. The only time I do 2 is if I'm doing a pure injectable cycle. Sometimes we do 2. There's a study that actually came out of Texas Fertility Center a number of years ago that showed with injectable gonadotropins that 2 did improve pregnancy rates. Or if I have somebody who we've done IUIs and we have had less than 10 million sperm at the time of IUI, sometimes I'll do back-to-back IUIs. That is because I logistically am about 40 minutes away from where things can be frozen or things like that, and people who are wanting to try anything. So we do occasionally do it in that situation. But if you got good sperm, 1 well-timed IUI is all you should need.
And if you can have sex, great. Count that as your second sperm exposure, but that second IUI doesn't help a whole lot unless you've got some extenuating circumstances like what Susan's dealing with. Lots of good questions today.
All right. Well, any closing remarks by anybody?
Well, I think we talked about a lot.
Yeah. No, we love your questions. Keep them coming.
Well, so to our audience, thanks for listening. Tune in next week for more. Also, be sure and subscribe and leave a review for us in iTunes. We'd love to hear from you. You can also follow us on Instagram or Facebook. So hop on and leave us a like or a comment.
You can also visit fertilitydocsuncensored.com to submit specific questions you have about infertility. All the questions we answered anonymously on our Ask the Doc segment. So don't hold back. We love episode ideas, and let us know what you're thinking and what you want to hear about.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. We'll talk to you all soon.
Bye.
Bye.
Bye.